This is Just Say HIE, the official podcast of the Hope for HIE Foundation. I'm Betsy Pilon, your host, bringing the stories of the HIE community from around the world to you, our listeners. Hope for HIE is a nonprofit organization and the largest collective of HIE families anywhere in the world, and each story across all outcomes has its own version of hope to share. Join us as we explore each unique journey and connection. Welcome, everyone, to our next episode of our Just Say HIE podcast. I'm so excited today to welcome two neonatologists who work at the hospital at Nova Southeastern University in Florida, Drs. Daphna Barbeau and Ben Courchia. Welcome to you both. I'd love to hear just a quick introduction from each of you about a little bit about your your experience as neonatologist, how you got into the field and what drew you to neonatology.
Well, I got into neonatology in residency. It was actually a funny story. It was one of the few fields that I thought I would never go into. I thought it was a very intimidating place. But after my first few rotations in the NICU, I was fascinated by the ability that the clinicians had to make a difference in not just a baby's life, but in a family's life. And I just fell in love during my first year of residency. And I haven't looked back since. And I've been, I feel like it's been a very fulfilling experience to be a neonatologist.
Wonderful. Yeah, my path, I was in the third grade when I said I wanted to be a baby doctor, and we just thought that might be something that came and went. But I agree. I liked the initial acuity and the opportunity to do procedures, but I knew that I needed to be somewhere where I would have the opportunity to form relationships with families and walk with them as they faced some of the most difficult things they'd have to face in their lives, and hope that I could play a role in that transition. And so certainly as a fellow in my training, I was lucky to have a mentor that is very much a part of the HIE community here in Florida, Dr. Michael Weiss, and so HIE and neurodevelopment has been an ongoing passion for me. And so I'm especially thankful to be with you this morning.
Wonderful. I'm so glad you both could join us, and so grateful for the work that you do for families. So I'd love to start talking in this episode a little bit about what you see from your perspective and the challenges that you face as neonatologists with the HIE community, because it is definitely something we talk about in our community all the time, of being kind of the atypical NICU experience. You think about going through, from the parent perspective, a pregnancy, and you think, oh, if I get past 36 weeks, I'm good. Or, my child might, if they come out with a C-section, maybe they have wet lungs and they need to be in the NICU for a day or two. So, which is probably a totally ridiculous thought to go through, but that's kind of where we are with society. So, if you could talk through a little bit about your experience about the, babies that you see, and kind of, I guess how often, or, what kind of is that physician side of things when you get an HIE baby on the unit?
Yeah, for me, right out the gate is I'm a talker, if you can't tell, and I'm a knowledge is power kind of gal, and so for me, it's striking that balance between giving parents enough information versus towing the line to totally overwhelming them with too much information, and that changes from day to day, it changes from family to family. So I'm always feeling like I have to rebalance what I want and can share. And the only thing I found to be useful is just checking in with families and saying, how much do you want to know. Are you available to accept this kind of information right now? Is there someone else we can call to help you process some of this information? But I'm looking for more opportunities to help balance that. So if you've got any for me, I'm happy to hear them.
For me, it's the experience of HIE in the NICU from the clinician standpoint is one of fear. And I'm using the word fear because when a baby arrives in the NICU with a potential diagnosis of HIE, number one, we don't have really a test that can determine yes, no, this is the situation. That's it. The baby has been diagnosed. So there's this anticipatory phase where it may be what it is, it may not be, we don't know. And like Daphna said, it's about towing the line. I don't want to convey a huge amount of drama to the family because in my head, I know what severe HIE looks like, and I'm frightened by the fact that this may be what's in front of me. But on the other hand, I also feel like, what if this is a case of very mild HIE? Mm-hmm. I don't want to really overburden this family with information that is going to depress them, make them anxious. I want to avoid that. And sometimes you even find yourself on the other side of the spectrum, mm-hmm. where you're saying, if I put this baby through therapeutic hypothermia and cool this baby, and then I'm just being overcautious, people are going to sort of dismiss me as this over anxious doctor saying, oh, he put our baby, everything was fine. And all the while, maybe they don't realize what's lurking in the back of my mind. And so it's fear, it's panic, and because HIE is such a time-sensitive issue, the pressure of time and the pressure of making the correct decision makes this even more so in terms of anxiety for physicians.
Yeah, I think we share some of the same feelings that families do, because we want success for your baby in whatever that means, whatever success, means. We want the best outcome that can be achieved given the circumstance. We feel a lot of pressure to optimize the care given the constraints we have of the diagnosis and the therapeutic options that we have. And we're ever the optimists, right? We know that the potential for something dramatically a poor outcome is possible, right? For any of the babies, and we don't know necessarily yet which babies will do well and which babies won't. And we're also balancing our reality with our ability to stay hopeful with parents. So it's a challenge for us too, emotionally. I think in the unit.
Yeah, it's, and these are the complexities. I think with HIE, we see it's just, as you said, there's so much complexity and so much unknown and uncertainty with it, with, I think, almost every case. And you have that spectrum of outcomes and that spectrum of presentations. And there's a lot of discussion right now on the maybe babies and those that, and we just, we talk about this. We have families whose kids will, they'll be born pink and have good APGARs, and then they tank out at like 12 hours post-birth and start having seizures. And it's like, what can we do? What are those, signs that might have been present that could have, given us a better indication? And it's something that, in the evolution, and I try to point this out as often as we can, it is still kind of in its infancy of HIE treatment. And we're kind of at this precipice where there's a lot of different neonatologists and pediatric neurologists looking at how can we better identify and treat, quickly, because it is that window. It's that 6-hour window. And we've tried cooling after the 6-hour window, and we've tried cooling longer, and we've tried cooling deeper, and, all of these and earlier, all of these different things. But there still seems to be a wide variety of, what guides. There's like the general guidelines of cooling, but but there's so many kids that fall outside of that, and we hear as parents, those more mild kids who miss out on cooling, or, for some reason, maybe they weren't as mild, or they were, very sick at birth, and then within 2 hours perk up, and then they go, oh, maybe we shouldn't cool these babies. We hear from parents. I have yet to hear a family that says we regret our child being cooled.
Yeah.
I would love to hear your perspective on that.
That's an interesting perspective, because I try not to, but I do ask myself sometimes, if this was my baby, what would I do? What would I want? And sometimes we still don't know the answer, right? Because the studies just haven't been done yet. They are being done. And so I'm thankful that through, grants, and certainly through the advocacy of parent groups, that we're able to do the work, and certainly through the trust of parents who are willing to enroll at such a chaotic time in their lives, babies into research, that we're doing the work, right? We're trying to answer all those questions, and we just don't have them yet. And you described certainly an unfortunate situation where maybe we didn't get the opportunity to make a decision because the baby was well appearing and then presented with seizures. And I don't know that we'll be able to change those outcomes, unfortunately, even given all of the work that's being done. But I'm hopeful in the next 5 to 10 years that we'll be able to answer some of those other questions. Is how can we, using blood biomarkers, look at babies who had some sort of event that maybe we didn't even notice clinically, because we can't know everything going on, and having some more information both clinically, using some of the vital signs like heart rate variability, and again, some of these blood biomarkers that may say which of these babies will benefit most from the interventions that we are going to perform, because the intervention itself can be quite stressful for babies and for families. And so there's some risk to doing some of those things. So, which babies will benefit and which babies won't. And then certainly there's just a gamut of new therapeutics that are being trialed that I am very hopeful about, that will help us augment therapeutic hypothermia, or those babies that have not qualified for cooling, and that will have more to offer them.
Yeah, I mean, I agree with you, Daphna. I think there's something interesting about therapeutic hypothermia in the sense that it is sort of the only thing that we have in our arsenal to combat HIE, because we have to also be realistic. It is not a cure. It's not like, oh, if I had cooled the baby, everything would have been perfect. We would have gone back to baseline and the development would have been normal. So it is a mitigating tool that we have that is not perfect. And it's the only thing that we have. So we're so focused on it. The other issue that I have with cooling is that we tend to wrongly think, especially as clinicians, that it is a benign procedure.
Mm-hmm.
And we say, what's the harm? And it's true that it's mostly the negative side effects of cooling are minimal. But when you actually do your homework and you go through the literature, number one, you see that babies who are being cooled outside of the criteria that have been laid out do have some complications that can crop up. A baby that is a bit more premature than you anticipated, who suddenly becomes coagulopathic, that's a big deal. And that really makes you think twice about trying to make the right decision when it comes to cooling. And now there's more animal data coming in saying that sometimes cooling can cause, at least in animal models, some neuronal apoptosis, which is not what I want to see. And I think I personally, at least, I am lying to myself, because if a procedure seems to be perfectly benign with no side effects, you're missing something. Everything has side effects. And the fact that these side effects for cooling are just starting to come up makes sense, but it makes the decision to go for cooling even more difficult. Because like we used to think, oh, I'll just cool this baby, and what's the worst thing that can happen? Well, there's some nasty things that can happen. Aside from the separation between the baby and the mother, aside from the trauma that the parents go through during the cooling process, aside from the altered nutrition and increased mechanical ventilation, all these things that pile on to the therapeutic hypothermia. So it's becoming harder and harder to navigate HIE because, like Daphna said, as clinicians, we care and we feel like we have skin in the game in the sense that we want these babies to do well. We don't feel detached at all from the plight of the families. And so as an intervention becomes a bit less obvious to use, it makes it even more difficult to us because then we're sort of left with what else can we do? So it's extremely complicated and difficult.
Yeah, I think also some of our experience is that even in the right baby with the right diagnosis who got everything went the way it should with therapeutic hypothermia, our children still may not be typically developing. And so often, we feel like, well, gosh, did we do everything we could? Did we do everything right? But that's a success, right? To give a child maybe more opportunities than they had, even though maybe their life doesn't look exactly like parents had anticipated, or it doesn't look like a baby's who didn't have HIE. But it's hard for us too, when we feel like we didn't give parents exactly what they were expecting, but that had we not proceeded with some of these interventions, that we just don't know, what the outcome would have been. So, I hope parents, and I don't think they always feel that from physicians, but we do care about the babies, and we go home thinking about our babies that are cooling, and they're the first babies we visit in the morning. For sure. And I can just see how much the waiting affects families, the waiting and that not knowing. And for us to say, we're going to do this for 72 to 96 hours, including rewarming, and we don't know. And that becomes increasingly difficult for us to say, I'm going to be honest with you. I don't know, but I'm hopeful. I'm hopeful that it's going to give your baby the best outcome possible, given the circumstance.
That is that remark is so poignant, and I wish we could just copy and paste that for so many other families, because that is the meat of where we are with HIE is, what is that individual child's potential,
right.
and how do you maximize that, and my next question really is, because I think about this a lot because of the people that work in acute care situations, neonatology, pediatrics, adult medicine, acute care, you talk about bringing that home. And I know that, physician burnout is at an all-time high. And I think some of the most compassionate and amazing providers that I've ever seen are acute care specialists, whether it's in neonatology or adult medicine. How do you process those difficult days with cases that, especially babies are so unpredictable. How do you maintain a balance of that work life, not taking all these burdens on and processing through, because that's a lot when you're in it. And you both sound like such incredibly compassionate, physicians that are in, arm in arm with these families.
Well, we're trying. And sometimes it's hard. Sometimes it's hard to not take it home. Sometimes it's impossible to not take it home. I think we have understanding spouses, and we have mature for their aged children who let us give us our time to decompress, who let us recheck the charts in the evening and overnight. And I think that one of the most important aspects of my job is what brings me the greatest passion is being able to connect with families. And I think in an effort to keep doing the work and to protect themselves and to not bring it home, there are physicians who don't take the opportunity of diving, right in, even though they feel it and even though it affects them, because they want to keep doing it for decades, and it does take its toll. But for me personally, relationship building is important. Is I think my end all be all. So for me, I there's no other way for me to do it, for me to continue doing the work, but to form relationships. But I understand why so many providers, physicians don't, because it does make it harder, because we do get attached. And like Ben said, we have skin in the game. I mean, we want the best possible outcome for every baby that comes into our care.
Yeah, I mean, from my standpoint, it's a difficult question to answer because we try, but we fail most times, I think. And I think it's a multifaceted sort of approach. I think my wife has developed a sixth sense. So if I get home, she'll say, "What's wrong?" She'll know right away on my face that something is bothering me, and she'll usually send me out of the house for a run or just to decompress. And I'm very grateful for that. I think the most important aspect is communication, mostly with your peers. I have found that there's an important aspect of trusting your colleagues. And so when we do hand off patients at the end of the day, at the end of the night, it's important to communicate not just what's objectively wrong with the patient, not just what are their ventilatory settings or their vital signs and so on, but just say, hey, here's what I'm worried about. This is what's bugging me. It's maybe irrational, maybe it's medically not founded, but this is what's on my mind. And then sort of passing the hot potato to somebody else who's going to mull it over and try to think about it in a different light. I think that has helped tremendously, because when you trust your colleagues, then you'll know that they'll follow through on what's been on your mind, and they'll sort of take that burden away from you. And I think when things don't go as well as you would like, I think it's important for everybody to find this one person. Sometimes for me, it's a person that's a bit more senior than me in years, and just having an ability to run how things unfolded, and have a person being critical, not being sort of depreciating, but just saying like, this is what I would have done differently, just so that you feel like you're making progress. Because it's very easy when things don't go the way you like them to go, to have people sort of to empathize with you and say, oh no, you did everything you could, but that's really not what we're looking for. We're looking for, how do I get the next baby that's coming around to have a better outcome each and every time? That's sort of how we get better. And so at the end of the day, all these different facets of how we handle stress with the NICU and HIE specifically, I think boils down to communicating with your spouse, with your colleagues, with your mentors, and just, taking it one day at a time.
I also think for families, not all physicians show their love in the same way, right? So you may not have the most warm physician potentially, but they may be the physician in the unit who is doing the QI, who's running the checklist, who's looking at did we meet all of our metrics? Did we do all of the right labs? They're the doctors who are working on something you've shared as part of your experiences. How do we better, more smoothly do transfer to higher level of care and back to lower levels of care so that families can have a better experience? They may be the physicians who are doing the outreach to community level providers so that we do better recognize the early signs. We have more optimal management in that first 6 hours. And so there are lots of people who are throwing themselves, for example, they've stepped out of clinical care altogether and they're just doing the bench research, who are giving everything they have to try to optimize care. But it may not always seem readily available or present to families. And so I think that's how people manage the ongoing stress.
Mm-hmm. And, bringing up communication, I think, is so important, because when we talk about the interactions between, patients and families and physicians and other providers in the NICU, it's such an intense time and for everyone. And so I want to talk through a little bit, because for our families in particular, things that I see, I have a background working in health systems, so walking the halls of a hospital is nothing new for me, going through different situations. But for a lot of people, this might be their very first time in an acute care situation, or anything more than just, if they were good about preventative health, going once a year to their physician. And then, obviously prenatal care, you see someone a little bit more, but you never expect to be in kind of this intensive care situation. So it takes people by, definitely by storm, and communicating in the throes of a very difficult or traumatic situation. How do you approach that as a physician to get everyone on the same page? Because it is team medicine. You have, bedside nurses, you have, respiratory therapists and other, NICU therapists coming in and out, hopefully social work and things like that. How do you kind of serve as that quarterback of the team as you're, providing this care?
Well, maybe we should ask you how you think we're doing with that, because parents perceive all sorts of things about those first few days. And I think communication is complicated, but and there are multiple types of communication happening. Like you said, it's physician to parent, it's physician to physician, it's physician to respiratory therapist, social work, nursing, nurse to nurse. And the skills are transferable, right? We're all just people working in the system, just like, some of us are parents talking to other parents, but the stakes are high. And I think that's really where so much of the work about regionalizing care, making sure babies can get to the right level of care when they need to, about standardizing care. And so thankfully, the way at least the cooling studies have been done, most centers are doing things in very similar ways. And as the studies continue to unfold, we're adding to that and we're refining that. And so some of the communication is happening just in terms of having policies and protocols and guidelines that, at least as a team, we can agree to and adhere to optimize care. And so when we can take away some of those extra decisions, hopefully it allows for more thoughtful discussion about the individual needs of an individual baby that may not be following the pathway exactly as we had hoped or anticipated, and then giving us the opportunity to work with parents who, it's shock, right? Those first few days can only be described as shock. And some of our families, not only do they have a sick child, but they have a sick mom, or the mom herself had a very difficult labor, delivery, herself had surgery, trauma, and gosh, it's overwhelming for families. I'm impressed that families ever make it through the first few days, and they always do. And some of that has nothing to do with our ability to communicate with them. It's just that parents are resilient.
Yeah, I agree with you. I think we have to capitalize on this resilience. The way I tend to see it is that I assume that parents see the NICU and everything around the NICU as negative, and negativity has its contagious sort of ability. And so I'm trying to protect the baby and the family from this negative sort of influences. I try to establish communication a bit like running a code, actually trying to assign roles and tell the family what the role of everybody is, and put it in perspective of their babies as a normal baby, not as an HIE baby. So for example, the nurse is meant to make sure your baby gets fed and gets changed. This person is here to make sure your baby eats okay and looks at how well your baby is sucking, and so on and so forth, and try to leave the tough discussions to very compartmentalized areas. I think if possible, negative discussion has to have to happen away from the baby's bedside. I think everything has to be sort of done in a bit of a vacuum so that we can leave a protected space around the baby. In terms of communicating with parents, I think we as physicians dread having to give bad news to parents. And so especially when it comes to HIE, I think this is sometimes unavoidable. And so whenever I have any sort of mildly positive news to give, I make sure to make a big deal out of it and sit the parents down and try to convey to them that it's not going to be all bad news. We're going to have those unfortunate discussions at some point if we have to have them, but I cannot make this hospitalization be completely a set of negative news one after another. And so if a baby, like we had discussed before, if a baby is able to come off mechanical ventilation, even if that's expected, then that's a big deal. We have to make a big deal about it, because we have to create these positive sort of momentums where parents sort of feel like there's room for progression, there's room for improvement, because otherwise, like we always say, if you take away hope from a family, then there's no point in fighting anymore. And we want to have everybody keep fighting. And I think that's where it's very important.
Yeah, we call those inch stones in our community. So, I had a friend a long time ago that, he quoted Michael Jordan. I coached high school kids for a long time. So, and he said, Michael Jordan says, don't celebrate every win, don't celebrate every basket. And I was like, no, like my philosophy has always been, you need to celebrate everything. And then in HIE, you really celebrate everything. It's, that's where you build on those small wins and they add up. And that's where I love that, because that's where you feel empowered as a parent, because you can have that series of small wins and really start to, whatever that path is, every child has those small wins. So,
and I think in sports term, there's this idea of the win streak, and it's a complete statistical fallacy. I mean, it has no basis whatsoever, but we still have to capitalize on it. I feel like when we feel like there's I think it's called the hot hand fallacy, but yet we just have to establish that in the NICU, because we don't want to establish the cold hand fallacy where it's like, oh, this guy's coming around again. What now?
Right.
And also, I'm sorry to say, but in today's medical climate, because of liability and legal matters, there's a sense that doctors have to communicate everything at the millisecond that we get the information. It has to be passed by. And I've found myself many times where I had something difficult to tell a family. I would swing by the bedside, and you see that the family is having a cherished moment with their child, and you're like, you know what? I'll come back. And it may not fit my schedule, and it may make me stay sort of later, but we have to be cognizant of these moments, and give, like we said, give room to the families. I think it's something that we don't talk about enough, and we want this direct line of communication that's going sort of fiber optic, but sometimes we have to, as physicians, without saying that we're withholding information, but saying, when and in what circumstances am I gonna disclose certain things to the parents? Well, if I walk by and the mother is doing skin to skin, that's not the right time to have that discussion. I will let her finish and I'll come back. And that's tough for us, because it takes time, and it may not be the most convenient, but it's so important, I think, for everybody, that it makes a difference.
Well, and that makes me think about, Ben, how you said you have this team based approach, which I think parents like, and when you're assigning team roles, I'm hopeful as a medical community that we're really looking for an opportunity to give parents their role back, right? So I feel
I
like,
actually,
yeah.
Yeah, actually, that's something that I make sure to say to the parents because I know that the NICU is, like we said, it has this contagious effect. And I say, listen, you're going to feel like you're going to need to become the nurse and the therapist or the doctor. You are not. We are here to be those people. You remain the parents. And sometimes it's too vague, I found, that to tell the parents, hey, be a parent, they're like, what is that supposed to mean? Like, I don't
Right.
get to. What a parent is, my mentor used to say, what is the job of a parent? Truly, in a very cynical way of looking at a parent of a baby is sort of to feed them and change them. There's not much more in terms of tasks. And when you're in the NICU, those are sort of taken away from you because if you're not there to do the diaper change or if your baby is on IV fluids, then you don't have these things. And so I feel like it's important for us to remind parents, what does it mean to be a parent in the NICU? Come speak to your baby, read them a book, show them pictures, all these different things that they may not conceive as potential things they could do with their baby in the NICU. It's up to us to remind them that this is what it is to be a parent. This is what you would do if you were at home. Try to recreate that, even though it's extremely difficult for parents to sort of feel comfortable in that setting.
Yeah, I worry that parents see it as a spectator sport, right? That things are happening to their baby, things are happening to them, whether and some of the things they agreed to, some of the things they didn't agree to, but it's all just happening, right? And when they're in that state of shock, it's really our job to try to say, let's bring you back. Like, there are some things that need to be done for your baby that I can't do, right? Your baby recognizes your voice, not my voice. And so the only thing that can potentially bring your baby comfort right now is you. And I'm hopeful that as a community, we're working on it. A lot of our mindset is focused on the numbers, how do we keep the blood gas right? How do we keep the coags right? But as a community, we are working, hopefully every day, a little bit harder to empowering parents to say, we still need you. The best way for your baby to be successful is for them to feel safe, is for them to feel comfort. And I can't do that for your baby. Only you can.
And
And
it's important to mention the statistics. I mean, we give them statistics all the time
all
when
day.
it comes to prognosis. And so I feel very comfortable telling parents, studies have shown that if two babies are next to each other in the NICU and one baby has parents visiting more frequently, well, long term, years down the road, this baby will do better.
Yeah.
And I tell the parents, don't ask me how. I cannot give you a perfect mechanism as to how that works, but this is what we found. And I feel like this is just as important as any prognostic information we give when it comes to an MRI or a head ultrasound. And parents need to understand that their presence matters, even if it feels mystical, then so be it.
Mm-hmm. I love that. And something that, this kind of brought up two phrases actually that I wanted to kind of talk through and get your perspective about, that we try to combat because it does not, they're barriers to connection and care. But when you talk about statistics, and I think this phrase is rampant in any sort of medical situation with patients and families, of defying the odds, which I absolutely loathe this phrase because I think it's loaded. So you look at statistics and you can give numbers, but like, what odds are we talking about here? You know what I mean? It's like, that's one of the things that I think I'd love to see shift. And we try to shift on our end of the parent end, because, HIE is so individual. And when you can look at statistics, certainly, but what is the baby clinically doing, and what does that match up to? And so I'd love to talk through that a little bit with both of you and what your take is on that.
Yeah, for me, I there are parents who love the numbers, who want the numbers. And for me, I say, I'm happy to give you the numbers. I have the numbers. They're right here. For some things, not for all things. But I've always said to parents, and maybe this isn't the right thing to say to parents, but you only have one baby, right? And so their outcome is either this or this or this, or their risk factor is either this or this or this, or they had the side effect or they didn't have the side effect. So it's not 96%. It's not 50%. For you, it's 100% in your one baby. And so the numbers give us faith sometimes in the work that we're doing, that we're making the right individual kind of clinical decisions. But the truth is, I find that they're really difficult to interpret when your baby, is the one in whatever. And
Right.
it's so hard because we all have a different idea of what is quote unquote a good outcome, or quote unquote a normal outcome, or a typical life. And what I see in parents, particularly parents who have children with medical needs or who have complex care, is, I mean, they can do things that the rest of us don't do or can't do, and is find really the joy in what you said, those inch stones, right? Things that happen every single day in our normal, quote unquote, typical lives that we miss. And parents of children with HIE are really just capturing joy every single day. And there's something to be said for the ability to do that. And statistics just don't give that the due diligence. To the contrary, I think they take some of that optimism away.
Well, and then people just get so, no, that was great. I think people just get so caught up in it. So then, like, yeah, we try to educate and say, yes, your child might have been very sick when they were born and going through, their NICU stay. And like parents have this, it's hard for them a lot of times to wrap around again, this lack of a crystal ball.
Yeah.
Everyone wants it, of course, but and reconciling that you had this very sick baby, and maybe they, their outcome is great. Although I think a lot of people, like to your point, and we hear this too, families with children with disabilities, they think their outcome's great too, because they have a child that's living and doing different things that they didn't anticipate, and they can do things in different ways and find that joy. So, yeah. So anyway, Ben, what's your take on this?
I fall very much in line with what Daphna just said, and I have used now and stolen a sort of response from Bruce Schulman, who's one of the physicians we worked with, who kept telling parents this. He said, "I'm going to give you statistics, but just know that you're running your own study, and your N is 1, and that's your study, right?" And that's so true. Like Daphna said, we can give you statistics, but you shouldn't care too much about statistics, because you're running an extremely biased study of your own with only a single patient. And your study results may be not applicable to others. And so that's how you have to see it. And then I try to I think you touched on, Betsy, the concept of uncertainty. And I think sometimes I find myself being a bit blunt with parents and saying, well, what is your prognosis? What is our prognosis? We all have 100% mortality rate. We know that this is awaiting all of us, right? Death and taxes is the only certainties in life. And so we know, and even that, even though we know that death is a certainty for all of us, then when is that going to come about? We all of us don't know. And so if we reframe our goals and our objectives, then we say, whatever time we have ahead of us, let's make the most out of it. And that's how we have to approach everything. And the potential for growth, I think, is always present. And the ceiling for growth is really what the true unknown is. So that's all really that's going to matter in the end, is that did we maximize our potential? And for most of us, the answer is always no. I feel like so what's the difference in the end,
Well, wow, we have covered a lot of ground today, and I just so appreciate both of you for sharing your humanity and your perspective, because that's something that we don't hear a lot of. That just kind of behind the scenes look at how you feel about the work that you do, and how you go home at night and or in the mornings, depending on your shift and how things go. I guess I'd love to hear any final thoughts you have, things that you feel like, one thing that you want parents to take away of what you hope their experience is when working with their NICU teams.
Well, we talked about communication, and sometimes, as hard as it is for parents to find their voice in those first few days, I think we need from families too to say, this is how I would prefer that information is communicated to me. Because it's different for everybody and we don't know. But if you can tell a provider, I prefer that you talk to me when this, or, I really am going to need my partner, my mother here when we talk about important things. And that's just not just for the NICU stay, that's for forever, right? For your outpatient care, for your therapy care. If you can tell people who will be giving you news how and when you prefer to receive that news, I think that's helpful for everybody, and gives us the best, most effective type of communication. So I hope that parents are empowered to tell us that, to tell us what their communication style is. And some of us don't find out until we've been thrown into a situation like this anyways, right? How we best prefer to receive information. But sooner or later we figure it out. And I hope parents will share that with us. I hope that from this, parents feel like, regardless of our array of personalities, that we care about your babies, and we want them to have the most optimal outcome, whatever that means. And that's different for every baby, and we understand that. And that we're working as a community to change our lingo, to change our the way we talk about some of those outcomes. Is, when we can say to a family like, your baby is destined for a poor outcome, that we steal some of that joy of what it is to just be a parent and to love your baby and to have a child who can receive your love. That we're working on it as a community to try to give back parents some of the routine parenting that they can and should do.
Yeah, I'm gonna sound like a broken record, but I agree with Daphna, and I fall in the same lines. I think the communication in the NICU is extremely sophisticated from a scientific standpoint. I think parents are thrown into a dialect that is complicated. We talk about settings, lab results, all these things, and as providers, we tend to expect the parents to meet us somewhere. I mean, we may, like Daphna said, use more layman's term to try to make it understandable, but it's still a big jump for parents to sort of try to understand what we're talking about, what are the implications of every single lab result. And so I have sometimes found myself trying to tell parents and encourage them to do this, but I think every parent in the NICU should know right away or organically that they must do the following, which is just come out with what's on your mind. Mm-hmm. I think if you're a parent in the NICU and you have a baby with HIE, well, when the doctor comes in, before you even start talking about anything, if you're worried about, is my kid going to be able to go to school? Just say it, because it does create an anchor for us to sort of say, well, now I understand what's on your mind, and I'm going to try to tailor a little bit some of my discussion to answer that question. And it's something that if you let a doctor or a neurologist sort of talk about MRI results, we may never get to. But if that's what the parents has on their minds, then it needs to be addressed almost immediately. Because then once that's addressed, then I think parents have suddenly an answer to a question and they're able to listen to whatever you have to say afterwards. So I think it's very important to have parents be frank and be open about their concerns. Is my baby going to survive? Is my baby going to be able to eat by himself or by herself? then let's just come out with it. Just say it. Let's talk about it. And that's, I think, sometimes even more productive than going over what is the latest sort of CO2. It really sometimes doesn't make that much of a difference compared to discussing those types of concerns.
Yeah, they call that in outpatient medicine the door on the hand on the knob question. So the physician's already on their way out the room, but the family noticed, I sat and I listened, and we had a good session. I had a good visit, but I actually didn't get the answers to what I came here for. And so Ben and I don't always agree on everything. It must seem like we're always agreeable, but this is rare. But come with your list of questions and come out with them, because it may change our discussion entirely. I found I give a parent an update, and at the end of the update, the parents' only question was something that I didn't even think to talk about. So yeah, I think knowing what your concerns are in the moment, and that may change every time we meet, are important to us.
Thank you both for, again, all the work you do. I'm really excited. This episode is a 2-part episode, one on your new podcast, and then you joining us for our podcast. And I love when we can collaborate. And I just want to thank you both again for all the work that you do for the families you serve, for taking the time today, and for being so open and willing to collaborate. It's just been so fun.
Thank you so much.
Thank you, everybody.
Thank you for joining us for another episode of Hope for HIE's official podcast, Just Say HIE. If you have a story you'd like to share, be sure to keep in touch. Learn more about the work we do and sign up for our newsletter on our website at hopeforhie.org/justsayhie. We look forward to connecting with you soon, and thanks for listening.